Respected chairpersons and moderators, my seniors sitting in the audience, dear friends and colleagues, thanks to Diabetes India, first of all. I am Dr. Anish Chandarana from Marengo Sims Hospital, a cardiologist. By degree, qualification and duty, interventional cardiologist, but has keen interest in preventive cardiology, and that's why I'm here for this talk. Now we all know that, can we have slides there? When we all know that atherosclerosis is a chronic risk factor driven immunoinflammatory disease with increased thrombogenicity. And we also know that atherosclerosis runs a very aggressive course in people with diabetes. So how to risk stratify people of diabetes at the right stage of atherosclerosis and how to implement different gravity of treatments at a given stage so that they can be benefited and treatment can be cost effective. So there are multiple trials, research data which has been there, and I'll discuss few of them, and then subsequently we'll discuss what is coronary calcium score and how to take it in patients with diabetes. Now we all know that diabetics are a high risk group, but they are very heterogeneous. Previously in late 90s or early 2000, we came to a dictum that diabetes is equal to coronary artery disease, meaning to say that everybody of diabetes should be considered as risk equivalent. But subsequently that was negated by multiple data that every patient of diabetes doesn't carry the same risk. The risk or the future cardiovascular disease risk depends on many things. Few of them are diabetes specific risk markers. Say for example, duration of diabetes, insulin dependence, the glycemic control, metabolic complications, kidney damage, and there are other clinical risk factors also which may coexist in patient with diabetes. So all this put together, diabetes is a very heterogeneous group. There can be a patient who is just recently detected diabetes, a 45-year young gentleman with mild obesity, HbA1c of 7.1 without any other risk factors. And on the other spectrum, there can be a gentleman of 70 years of age, 30 years of diabetes, multiple end organ damage. So obviously they both are not exactly at the same risk, and we have to define the treatment which bears some cost, which bears some complexities, and which has some adverse effect. So right treatment at right stage can help us a lot. So people who are symptomatic and diabetic, the algorithm as far as further course is concerned is reasonably well defined, but in asymptomatic patients who do not have angina or angina equal symptoms or who do not have ECG and echo changes, how to take them further is a serious question. I mean, this question has been answered by multiple trials. One of them was DIARD. That's where every asymptomatic patient of diabetes was subjected to either some kind of stress test versus people who were managed without stress test through proper optimum risk factor control. And at the end of 5 years, there was no difference in MI and death. What does it mean? That every asymptomatic patient of diabetes should not necessarily be put to stress test, because even if you put him to stress test, even if stress test becomes strongly positive, even if you take those patients to cath lab and do revascularization, ultimately, if you talk about thousands of patients at the end of 5 years, whether you manage patients by just strong aggressive risk factor control as per the guidelines, or you do stress test, the result is overall not different. Similarly, one such data was done, randomized control trial with CT angio for every asymptomatic diabetic patients. And even that strategy didn't help. So whether you do CT coronary angio for every asymptomatic diabetic person versus you don't do that and just keep them on proper management, again, the risk of MI and death doesn't differ. So it's $1 million question, how to pick up atherosclerosis at an early level and implement a strategy of treatment which is cost effective and risk effective, because there are certain treatments which are risky. Say for example, aspirin to be given for primary prevention. It's a risky treatment in terms of bleeding. So at what stage of atherosclerosis in diabetic patients, this all treatment can be adopted? That's something which is very useful. And that's where we all expect, believe, and there is good data that CT coronary calcium score can help us to risk stratify patients or people of diabetes who are asymptomatic. So mind well, first and foremost point is CT coronary calcium score is for asymptomatic people. Those who have got symptoms which are suggestive of ischemia, there is a different path. You need to have some kind of stress test or maybe luminogram. You may send them for calcium score, but stopping only at calcium score in symptomatic patient will not serve the purpose. So this is for asymptomatic people. What does CT coronary calcium means? It means there is atherosclerosis. Simple. It's not a risk factor. It means there is disease inside the coronary arteries. It gives a very small dose of radiation, which is 1 millisievert. It is measured in Augustine units, so quite well validated and there are no intra-observer or inter-observer variations. It is ECG gated because we want to pick up the coronary arteries in diastole. So that's why we take the ECG to the patient. But having said that, even those HRCT thorax which are done for pulmonology or other purpose, even they can pick up coronary calcium. And I have talked to many radiologists of this city at least that even if you do CT thorax for pulmonology patients, do mention there is coronary calcium present because that's where we can identify the risk. Total time is 5 to 10 minutes. Rupees 2 to 4,000 depending upon the center, and there is no preparation required. Patient can be empty stomach, patient can be full stomach, patient can be just walk in without any kind of thought, and patient doesn't need any kind of dye also. What does it suggest? It suggests increased future risk of MI, stroke, and cardiovascular death, and it is directly proportionate to the Augustin unit score. Higher the score, higher the future risk of cardiovascular events. So this is a wonderful data which was obtained from MESA trial, 6,700 patients or people who didn't have coronary artery disease to begin with. And when the score was 0, CT coronary calcium score was, for next 5 years, risk of CV events was very, very low. And as the score increases, risk increases in proportionate manner. Not only that, it adds to and it gives incremental value beyond risk factors. We all know that we just risk stratify people based on the risk factors. So say, for example, there is a person who has got 0 risk factors as far as cardiovascular disease is concerned. Now, if he or she has got coronary calcium score of more than 100, his future risk of cardiovascular disease event is very high. So generally, a person who doesn't have risk factors, we believe that he or she is at a very low risk. But looking to here, that person can have a very high risk. Similarly, there can be people who have got multiple risk factors. Say, for example, hypertension, smoking, obesity. But if their calcium score is 0, their future risk of atherosclerotic disease is less. So what does it mean? See, risk factors are risk factors. They give you probability of future risk of heart attack and stroke, but they are not the evidence of atherosclerosis. While CT coronary calcification is a hard evidence that the atherosclerosis has been there. To understand it better, to how it is used and when it should be used in asymptomatic people to detect presence, location, and extent of atherosclerosis in coronary arteries. CSE is highly specific. It is not just age dependent. Yes, there are a variety of variables which increase the coronary calcification, say for example, diabetes, chronic kidney disease. It also depends on age, gender, and race. But having said that, calcification is not just a normal process. It's a disease process. Higher the score, higher is the risk of atherosclerosis and higher is the risk of future events. 2 points which are very, very important at this juncture I would like to mention. Any score, however high, doesn't suggest degree of luminal narrowing, doesn't suggest the inducibility of ischemia, and doesn't suggest the need of angiography. So there is a very wrong practice which I see erupting in last 2 years where anybody and everybody with a calcium score of more than 0 is sent for angiography. That's an extremely pathetically poor practice. Whatever score, even it may be 1,000, 2,000, it doesn't indicate a need of angiography. It means there is atherosclerosis. Now, whether a patient has got atherosclerosis which is leading to luminal narrowing and causing ischemia is not depicted by calcium score. There are patients who have got calcium score 0 and still they can have unstable angina and disease. Even yesterday evening, there was one patient who was done CT calcium score just 1 day before, had chest pain, calcium score was 0. He was advised that it is gastric pain. Came to me, typical angina, did angiography, circumflex was 99% blocked and we did plastine, 0 calcium score. So a patient who is symptomatic, calcium score I do not believe has any relevance, but a patient who is asymptomatic, send them for calcium score. But whatever level of calcium score, you do not take a decision of angiography and angioplasty based on that. For that, you need another algorithm. There is something called as power of 0. When your calcium score is 0, your future risk is very low. But having said that, there are certain people like diabetes, family history of premature cardiovascular disease, familial hyperlipidemia, or smokers. That's where power of 0 doesn't work. So a smoker who has got calcium score of 0, you shouldn't grant him that he has got very low risk. So which are the patients or people who should be sent? If you talk about Western world, USA, everybody and anybody who's more than 40 years and has got intermediate risk based on the calculators, they are sent for calcium score. Now in India, we do not have risk calculators and that's why there is a big issue. So I personally believe every Indian, there is no consensus, but every Indian who is 40 years plus, I personally would send him for CT coronary calcium score, because when there are no risk calculators and when 1/3 of myocardial infarction in India happens before the age of 50, I'm very sure at the age of 40, you are going to pick up many youngsters with good amount of calcium score, and you can adapt preventive strategies. So when calcium score is 0, you repeat it every 5 years, maybe plus minus. But once calcium score is more than 300, there is no need to repeat, because more than 300 is the highest possible risk. So even if the calcium score increases in future, you are not going to change your treatment strategy. So once it has crossed 300, there is no need to repeat. A very important point, CT coronary calcium score does not reduce with treatment. So calcification and calcium score is always there and will keep on increasing. So you're not treating it. There are people who are coming out with chelation therapy to get rid of that calcium. These are all nonsense strategies. So what you are going to treat and tackle is the risk. You are not going to treat calcium. You are going to treat the risk which is depicted by calcium score. So just 1 minute more I will take with the consent of chairpersons. So when calcium score is 0, your future risk of cardiovascular event is less than 1% every year. If it is 1 to 100, it is 2% roughly. 1 to 300, it's 3% and more. So as the calcium score increases, your future risk increases. So every person with diabetes should be asked for lifestyle changes, glycated hemoglobin to be well controlled, metformin to be used, blood pressure to be controlled to less than 130/80. So every patient of diabetes does need this. But now the magic is, if your calcium score is 0, your future risk of cardiovascular disease for at least next 5 years is quite low. So that's where moderate intensity statin is good enough. You do not adopt any other preventive strategy in these patients. Obviously, in India, SGLT2 inhibitors are cheap and easily available, quite free of side effects. So you can use even at calcium score 0 as a primary prevention. I know that they do not reduce 3-point MACE in patients with got 0 calcium, but for the sake of cardiometabolic benefit. Once the calcium score is between 1 to 100, there is a high risk, and that's where you have to go for high intensity statin plus minus ezetimibe. And those who have got high triglyceride in spite of lifestyle and statin, you can think of eicosapentethyl. Now coming to a point of calcium score which is quite high, 100 to 400, that's where you have to start thinking about certain costly and risky molecules. Because you know that once calcium score is more than 100, number needed to treat to reduce event comes down drastically. So that's where if you use GLP-1 receptor agonist, that's where they will become cost effective. That's where you can use a low dose aspirin, because we know that when you use aspirin, after using in every 300 patients, it's going to cause 1 bleeding. So you have to find out a patient population where the benefit is much more than the risk. And they are the people who have got calcium score more than 100. And similarly, non-statin therapy, that is say for example, PCSK9 inhibitors, which are costly, you can think in this paper. So lower the calcium score, you can go ahead only with statin. As the calcium score goes up, you can keep using other lipid modifying agents, the costlier diabetes agents, and aspirin also. So ladies and gentlemen, coming to conclusion, CT coronary calcium score in diabetics is the most important tool to define the future atherosclerotic cardiovascular risk. But mind well, it is to be used in asymptomatic people, not symptomatic. It's very specific for coronary atherosclerosis. Higher the score, higher the disease burden, and higher the risk. It doesn't give any idea about need of angiography, angioplasty, or bypass. So please do not send your patients for those investigations based on calcium score. There is something called as power of 0. If your calcium score is 0, your future risk for next 5 years is pretty safe. But having said that, people with diabetes, familial hyperlipidemia, premature atherosclerotic cardiovascular disease, and smoking, they cannot be barred. They cannot be given benefit of power of 0. Once you do calcium score, it will help you to define the intensity of lipid lowering treatment. Moderate intensity statin, high intensity statin, ezetimibe. And once the score goes high, you start using, once it is more than 100, 200, 300, you start using aspirin, GLP-1 receptor agonist, and PCSK9 inhibitors. Thank you very much for your kind attention. Thank you.